Now we will move to, I will be the second speaker for pharmacological treatment of heart failure with reduced ejection fraction. Good evening, everyone. My assignment today is pharmacological management of heart failure with reduced ejection fraction. We know this slide very well by Victor Dezau on 1991, that in the presence of diabetes, hypertension, dyslipidemia, obesity, and other risk factors, this will lead to coronary atherosclerosis, myocardial ischemia, and with rupture of atherosclerotic plaque will lead to myocardial infarction. Post-MI remodeling, which is characterized by altered size, shape, and function of the ventricle and altered geometry, will end in heart failure, a progressive disease which is associated with high incidence of mortality and recurrent hospitalization. And mortality could be due to sudden death due to lethal ventricular arrhythmias or due to pump failure. And early in heart failure, there is a compensatory mechanisms which are characterized by neurohormonal activation in order to maintain adequate stroke volume and the cardiac output. Activation of the renin-angiotensin-aldosterone system, sympathetic system, arginine vasopressin, endothelin, which lead to salt and water retention with increased filling pressures, which are responsible for symptoms and signs of congestion. Peripheral vasoconstriction will lead to increased systemic vascular resistance, decreased stroke volume and the cardiac output, and the vicious cycle will continue. So in patients with heart failure, we are expecting to see high levels of plasma norepinephrine, plasma renin activity, arginine vasopressin, atrial natriuretic peptide, as well as endothelin-1 compared to normal patients. The deleterious effects of increased sympathetic activity with high level of norepinephrine will lead to increase the left ventricular volumes and the pressure due to peripheral vasoconstriction and the impaired sodium excretion by the kidney. Left ventricular hypertrophy. High levels of norepinephrine will lead to different arrhythmias due to increased automaticity of cardiac cells, increased trigger activity in the heart, as well as increased risk of hypokalemia. In addition to programmed cell death, which is apoptosis and a high level of oxidative stress. Activation of the renin-angiotensin system, which is characterized by a high level of angiotensin 2, which is known to be a potent vasoconstrictor, increased activity of sympathetic nervous system associated with high level of aldosterone, vasopressin, and endothelin, and it plays an important role in remodeling, increased myocyte growth, vascular smooth muscle growth, and increased collagen, in addition to increased inflammatory activity as well as pro-thrombotic activities. So the guidelines for heart failure ESC 2016, the goals of treatment for patients with heart failure is to improve the clinical status of patients with heart failure, improve symptoms and quality of life, as well as prevent the hospital admission and prolong survival. So we have many targets which can be plugged and modulated to improve the outcome of patients with heart failure. For renin-angiotensin-aldosterone system, we have ACE inhibitor, ARBs, ARNI, as well as aldosterone antagonists. For sympathetic nervous system activity, we have beta blockers. To preserve the endogenous natriuretic peptides, we have ARNI, which is Sacubitril Valsartan, and with elevated heart rate, we have ivabradine and beta blocker. For balanced vasodilation and oxidative stress modulation in African Americans, we have a combination of isorbitdinitrate and hydralazine. And to abort sudden death, ICD is mandatory as a primary as well as secondary prevention. And in patients with electrical and or mechanical dyssynchrony, we have cardiac resynchronization therapy, which improves symptoms, quality of life, improve ejection fraction, and reverse remodeling. And for congestion, we have diuretics to relieve symptoms and signs of congestion, and exercise training and rehabilitation for reduced exercise capacity. Regarding the use of diuretics in patients with heart failure, the key points which should be known that diuretics relieve symptoms and signs of congestion. However, they activate the sympathetic system and the renin-angiotensin system. So we have to use the lowest dose which can achieve evolemia, because it induces hyponatremia, hypokalemia, as well as hypomagnesemia. And it is not, it has no favorable effect at all on improving mortality. Diuretic resistance is common during the journey of heart failure due to poor oral bioavailability, compensatory distal tubular sodium reabsorption, and renal insufficiency. Thiazides and aldosterone antagonists should be given before loop diuretics, and don't forget concomitant sodium restriction. ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists are considered class 1A recommendation in patients with heart failure. Drugs which have been proved to reduce the risk of heart failure hospitalization and mortality. So all these three classes are considered class 1A for patients with heart failure and reduced ejection fraction. According to this slide, we can see that the use of ARBs in the form of candesartan in the SHARM reduced arm, it was associated with the reduction in relative risk reduction mortality 12%. ACE inhibitor Enalapril in the SOLVIT study, 16% relative reduction in mortality. And with the use of beta blockers, 34% reduction mortality according to CEPIS-2 and merit heart failure. And for MRA, a 30% relative risk reduction mortality according to the RALS study with the use of spironolactone. Regarding ACE inhibitors in heart failure, ACE inhibitors improve symptoms, improve clinical status of patients, as well as exercise capacity. ACE inhibitors improve cardiac function, reduce hospitalization, attenuate remodeling, and prolong survival, and reduce vascular events, and this was evident in HOPE study. Regarding the practical tips in using ACE inhibitors in the daily practice, it should be given for all patients with heart failure with an ejection fraction less than 40% and all NEHA classes. And we have to use the target doses used in clinical trials. Don't use many doses. Intolerance due to cardiorenal limitations is associated with poor outcome. ACE inhibitors can induce cough, angioedema, and anemia, and expecting increase in serum creatinine up to 30% after the initiation of ACE inhibitors. And the most studies have excluded patients with serum creatinine above 2.5. Regarding the use of angiotensin receptor blocker, we have many trials comparing ACE and ARBs like ELITE-1 and ELITE-2 studies, VALHEF trial, CHARM, OPTIMAL, and VALIANT. Some trials are post-MI, and there was no significant difference in mortality with using ARBs compared with ACE inhibitors. Beta blockers represent a cornerstone for treatment in patients with heart failure. And the rationale for using beta blockers is due to increased sympathetic nervous system activity in heart failure, the deleterious effects of increased catecholamine levels regarding increased myocardial oxygen demand and ischemia, increased oxidative stress, accelerating remodeling, and the low threshold for arrhythmias. Toxic effect of norepinephrine in the form of apoptosis and myocyte necrosis, in addition to down-regulation of beta-1 receptors. So with the use of beta blockers in patients with heart failure, this will lead to upregulation of beta receptors in myocytes, decreased myocardial oxygen requirements. It has an anti-arrhythmic effect, improved myocardial relaxation, decreased heart rate, protection against lethal ventricular arrhythmias, and correct the overactivated RAS system and reduction in the incidence of acute coronary events. And according to US carbidopa study, CEPIS-2, merit heart failure, Copernicus, bisoprolol, metoprolol, carvedilol were associated with significant reduction in mortality. So the practical tips in using beta blockers in the daily practice in patients with heart failure with reduced ejection fraction, it's indicated for symptomatic as well as asymptomatic ejection fraction with less than 40%. We have to use agents and target doses used in clinical trials, and should be initiated in the absence of symptoms and signs of congestion. Patients should be evolemic, should be off of intravenous vasoactive agents, and should be given prior to hospital discharge. Titration is mandatory when starting beta blocker every 2-4 weeks, guided by heart rate and blood pressure. To hold titration if the heart rate less than 60 beats per minute or a blood pressure systolic less than 90 millimeter mercury. And during treatment, you have to adjust other agents according to the clinical situation, the presence or absence of dyspnea, hypotension, weight gain, to achieve the proper doses to avoid decompensated heart failure. And if the patient developed acute decompensated heart failure, some practical tips and tricks which can be answered by Professor Frasbad. He's going to discuss how to manage acute decompensated heart failure and how to handle the different medications, especially the use of beta blockers. Aldosterone receptor antagonists should be considered in most patients with heart failure with an EF less than 40%. You have to keep eyes on serum potassium and creatinine, and should be contraindicated if the serum potassium more than 5, creatinine more than 2.5, and be cautiously in patients who are liable for hyperkalemia, elderly patients and diabetic patients, and to consider the use of eplerenone post-MI, and in those with side effects to spironolactone, especially patients who develop gynecomastia. Now we have ARNI or Sacubitril Valsartan, a drug which will preserve the endogenous natriuretic peptides, an liberalizing inhibitor which will prevent degradation of the endogenous vasoactive peptides, ANV, BNV, CNV, bradykinin, substance P, and all these vasoactive peptides have a beneficial effect in the form of vasodilation, decreased blood pressure, decreased sympathetic activity, decreased aldosterone, decreased fibrosis, hypertrophy, natriuresis, and diuresis. At the same time, liberalizing inhibition will lead to increased angiotensin 2. So the use of Valsartan to block the deleterious effect of angiotensin 2 at 81 receptors will avoid the harmful effects of angiotensin 2. So it will avoid the increased blood pressure, avoid sympathetic activity, increase aldosterone, increase fibrosis, and increase hypertrophy. So Sacubitril Valsartan, LCG696, this unique drug has a beneficial effects in preserving the endogenous natriuretic peptides, as well as blocking the 81 receptors by Valsartan. And we have the landmark trial, which is Paradigm Heart Failure, a study which included more than 8,000 patients with heart failure function class 2 to 4, with an ejection fraction less than 40%, when they're randomized to receive the cornerstone ACE inhibitor, which is an Enalapril 10 milligram PID, compared with Sacubitril Valsartan when titrated to the maximum dose, 200 milligram PID. The study, which were terminated prematurely after 27 months due to the overwhelming beneficial effect of Sacubitril Valsartan in terms of the primary endpoint, cardiovascular death or heart failure hospitalization. So we can see that the primary endpoint, which is composite of cardiovascular death or heart failure hospitalization, which decreased significantly by 20% compared with Enalapril, the number needed to treat was 21. Cardiovascular death decreased significantly by 20%. Number needed to treat to prevent this event was 32, and all-cause mortality decreased by 16%. So the use of Sacubitril Valsartan compared with Enalapril was associated with a significant reduction in all modes of death, all-cause mortality, death due to cardiovascular causes, sudden death, or death due to worsening of heart failure. So the last ESC guidelines 2016 recommended the use of Sacubitril Valsartan as a replacement for ACE inhibitor to further reduce the risk of heart failure, hospitalization, and death in ambulatory patients with HFrEF who remain symptomatic despite optimal treatment with ACE inhibitor, beta blocker, MRA, and this is class 1B recommendation. In addition, the use of ARNI Sacubitril Valsartan reduced the risk of hyperkalemia with MRA This was published in a study published in JAMA 2016, reduction of heart failure hospitalization within the first 30 days, absolute benefit across spectrum of patients with heart failure, and the benefit consistent regardless the background treatment. And in addition, compared with ACE inhibitor, it has a favorable effect for the kidney, less renal insufficiency. However, hypotension was more with the use of Sacubitril Valsartan compared with Enalapril. What about the use of the drug in patients with acute decompensated heart failure before hospital discharge? This is Pioneer Heart Failure Study, which randomized 800 patients to receive Sacubitril Valsartan compared with Enalapril, looking for the primary endpoint, which was the percentage of change in NT-proBNP. And within 8 months, the use of Sacubitril Valsartan compared with Enalapril was associated with 29% greater reduction in NT-proBNP. And if we look for the serious composite clinical endpoint, compared with Enalapril, Sacubitril Valsartan was associated with less mortality, heart failure rehospitalization, the need for LVAD, or the need for transplantation. So it can be used in patients with acute decompensated heart failure. And regarding the safety issue, which is very important, comparing Sacubitril Valsartan with Enalapril, there was no significant side effects compared with Enalapril in terms of hyperkalemia or worsening renal function, angioedema. Hypotension was common with Sacubitril Valsartan compared with Enalapril. However, it did not reach to a statistically significant p-value. What about remodeling after the use of Sacubitril Valsartan? This is a proof heart failure study looking for the reverse cardiac remodeling effect of Sacubitril Valsartan at 6 months as well as 12 months. And we can see that the ejection fraction increased after 6 months by 5.2%, and after 1 year by 9.4% in 800 patients given Sacubitril Valsartan. And interestingly, that 25% of subjects experienced an EF increase more than 30% at 12 months. And if you look for parameters of remodeling, we can see a significant reduction in left ventricular end diastolic volume index, as well as left ventricular end systolic volume index at 6 months, as well as at 12 months. And also the use of Sacubitril Valsartan was associated with significant reduction in the left atrial volume index, as well as a significant decrease in the E over A prime. So this study proved that not only a reduction in NT-proBNP level with the use of the drug, but also reduction in the parameters of remodeling. It has a favorable effect on reversing remodeling and increase in ejection fraction with the use of Sacubitril Valsartan. Finally, the use of IF current inhibitor, which is an evaporadine. We know that heart rate is important in patients with heart failure, and the heart rate reduction at the therapeutic target is important because this will reduce myocardial oxygen consumption, improve contractile performance, improve diastolic filling, reduce the risk of VF and sudden death, and promote reverse remodeling. And in the daily clinical practice, the use of beta blockers is underutilized and the dose is not reaching to the target dose. So if you have a patient with heart rate more than 70 beats per minute, using not adequate dose of beta blocker or not reaching to the target dose of beta blocker, evaporadine can be added, a class 2A recommendation, also in patients who have contraindications for the use of beta blockers. And we have the evidence from the SHIFT trial that the use of IF current inhibitor evaporadine in around 4,000 patients was associated with significant reduction in the primary endpoint, which was cardiovascular death and heart failure hospitalization, 18% reduction driven mainly by reduction in heart failure hospitalization. Finally, this interesting slide by the EC guidelines for the algorithm is summarize how to manage patients with heart failure with reduced ejection fraction. Diuretics should be given only to relieve symptoms and signs of congestion. Therapy with ACE inhibitor and beta blocker, up titration to the maximum tolerated doses. If the patient is still symptomatic with an EF less than 35%, MRA should be added, up titrated to the maximum dose, and keep eyes on serum potassium and creatinine. If the patient is still symptomatic and EF less than 35% with heart rate more than 70 beats per minute, ivabradine should be added. And if the patient is candidate for CRT based on a QRS duration more than 1 millisecond, CRT should be considered. And the patient is able to tolerate ACE inhibitor or ARBs, replacement with ARNI, Sacubitril, Valsartan should be considered. And in the presence of resistant symptoms, consider digoxin, hydrazine isorbitol combination, or LVAD or transplantation. And don't forget the indication for ICD in patients with EF less than 35%. Despite optimal medical treatment, consider the use of ICD as primary or secondary prevention. This is very important. Finally, the same recommendations, 2017 ACC expert consensus decision regarding the use of neurohormonal antagonist, ACE inhibitor, ARPs, ARNI, then MRA, and ivabradine, combination of hydralazine, and finally, the use of diuretics to relieve congestion. Thank you for your attention. You hear me?
Thank you, Magdy.
Thank you very much.
One of the questions.
I'm looking for the questions.
I will try to ask you the question since you are the speaker, if you want.
Okay, I have questions here.
How to manage hyperkalemia during upgrading interest to dose? The first question.
Yeah, this is very important. We have to, the baseline serum potassium is very important. The baseline serum potassium is very important. And after initiating the drug, we are following the patients guided by the blood pressure response and the laboratory. It's very important to look for the serum potassium and the serum creatinine. And hyperkalemia can be managed according to the doses. If the patient's serum potassium up to 5.7, you can exclude MRA if the patient's serum potassium is rising, and you can handle according to the dose. You can give the dose if the patient is on 100 milligram, you can decrease to 50, or if he's on high dose, 200 milligram. So according to the dose and according to the MRA dose which is used. So this is very important to monitor serum potassium accurately, because the risk of hyperkalemia is high, especially in patients who are elderly, patients who have diabetics, patients who are using non-steroidal anti-inflammatory drugs. So all these risk factors predispose patients to hyperkalemia.
Okay, the second question is, does ARNI inhibitors decrease cardiac fibrosis? Any evidence? Any evidence that ARNI, any evidence that Sacubitril Valsartan decrease cardiac fibrosis?
Of course, this is a very interesting question, because if we look for the mortality reduction, especially sudden death, which is due to ventricular arrhythmias, this proves that it has an anti-fibrotic effect, like MRA. MRA also decrease sudden death due to the anti-fibrotic effect. So Sacubitril Valsartan has an anti-fibrotic effect, which could explain sudden death reduction. And I think CMR guided studies looking for the benefit of the drug is focusing on this point, looking for fibrosis before and after the use of Sacubitril Valsartan, because this will answer the question regarding the favorable effect of Sacubitril Valsartan on fibrosis.
I have the simple question, which is regarding the introduction of the Sacubitril Valsartan in Egypt and the Middle East. We know that the major problem here is that ACE inhibitors and ARBs are extremely efficient, has extremely low side effects. in introducing sacubitril valsartan, we are faced with a very slow input of the physician to accept this new therapy. Do you think that in the years to come, this will change and sacubitril valsartan, backed by reimbursement by the health fund, will be introduced more and more?
This is a very important and very interesting question. This situation was present maybe more than 4 years ago when the drug became available in Egypt because the cost. But nowadays, the drug is available even in the insurance hospitals. So the reimbursement now lead to more use of the drug. And the use of the drug in Egypt, I think we have many studies which look for the outcome and for the benefit of the drug. So I don't think this problem regarding the cost, as long as the reimbursement is valid and we are using sacubitril valsartan on a wide scale in patients with heart failure nowadays.
Thank you.
Do you have time for more questions, or you?
As you like. If there is no other questions, we can move to Professor Firas Badr عشان احنا سهرنا دراسة النهارده.
I'm happy to be with you, Professor Magdy, but I do actually have a quick question for you. Because we're talking about the management of heart failure with reduced ejection fraction. Now, and I know Professor Severovich will talk about the SGLT2 inhibitors, and then just in the past few months, and despite the circumstances, there has been some momentum on even newer classes of heart failure and reduced ejection fraction therapies that might make their way into the categories of heart failure with reduced ejection fraction therapies. Do you see a challenge in adopting all of these classes as far as putting our patients on them, especially knowing that they're all going to probably be related to a little bit of hypotension and kind of difficulty of up titration, all of them together, you know, when you end up having potentially 6 classes of heart failure therapies that are known to reduce survival at some point?
I think this question can be answered after the end of presentation of Professor Severovich, because the use of SGLT2 inhibitors is challenging, and we will ask whether it's add-on treatment after sacubitril valsartan or the position of this drug in the armamentarium of heart failure therapy. So we can answer more after the presentation of Dr. Severovich, because I'm looking for this presentation because this drug have been proved that it's decreased mortality even in non-diabetic patients, so the benefit is high. So now we have many drugs, but the guidelines until now, it is ACE or ARBs, it's ARNI, it's MRA, it's beta blocker. We will wait the recent guidelines to answer these questions more for the position of SGLT2 inhibitor in patients' heart failure. And Professor Severovich will answer, I think, and will give us earlier expectations for the position of the drug in the new guidelines next year.
Yeah, and we just also heard about the vericiguat in the Victoria trial, and everybody is waiting for the omecamtiv mecarbil from the Galactic HF. So I think the next year is going to be exciting for heart failure therapies, more so for heart failure with reduced EF than heart failure with preserved EF, as we elegantly heard from Professor Leila. But I think it will be a little bit of a challenge to kind of incorporate all of these classes in our patients over time. We will see.
I have an interesting question here, asking for patients with COVID-19 on Entresto, when to hold and when to start. I think patients with heart failure, when they develop COVID-19, should be maintained on the drugs for heart failure. And the individualization of treatment should be considered according to the hemodynamic status of the patients and according to the clinical situation. Otherwise, if the patient is not hypotensive, is not hemodynamic unstable, is doing well, so for gut, and patient should be maintained on his optimal antifailure measures, ACE, ARBs, Entresto, beta blocker, etc.